But before I introduce our speakers and our panelists, I would like to say that none of them have any financial disclosures. Our panelists today, sitting right next to me, we have Dr. Alvin C. Bronstein. Dr. Bronstein is the medical director for the Rocky Mountain Poison Center here in Denver, Colorado. He is also an associate professor in the departments of surgery, the Division of Emergency Medicine, and clinical pharmacology at the University of Colorado School of Medicine in Aurora. Dr. Bronstein has authored a number of articles and book chapters in the field of medical toxicology and has written several textbooks on hazardous materials. He is the chairman of the AAPCC National Poison Data System Steering Committee and in charge of system development for that. He is board certified in medical toxicology, emergency medicine, and family medicine. And then we also have Dr. Margaret Thompson. Dr. Margaret Thompson is board certified medical toxicologist and emergency physician practicing in Canada. She is currently the medical director of the Ontario Poison Center in Toronto. And then we have Dr. Cynthia R. Lewis-Younger. She obtained her medical degree from the University of Alabama School of Medicine. She completed her clinical toxicology fellowship at the Oregon Poison Center, and she's currently the managing and medical director for the Florida Poison Information Center in Tampa. She is board certified in medical toxicology and occupational medicine. And we have Dr. Dawn Soley. She graduated with her Doctor of Pharmacy from the University of Florida College of Pharmacy, and she completed her fellowship in clinical toxicology and emergency medicine at the University Medical Center. She is currently the assistant director of the Florida U.S. Virgin Islands Poison Information Center in Jacksonville, Florida, at University Medical Center. She is board certified in clinical toxicology by the American Board of Applied Toxicology, and she is an associate professor for the College of Pharmacy and for the College of Medicine, Department of Emergency Medicine at the University of Florida Health Science Center in Jacksonville. So we welcome them. And our first speaker is Vicki Farnsworth. She's a pharmacist, C-SPI at the Rocky Mountain Poison Center.
Hello, poison people. I have never done this before, so I ask you to be gentle. My boss and my other boss roped me into this. So I was looking at the former years to kind of see how this case presentation went, and I noticed that they did a lot of differential diagnosis, and there's not a lot that really fits into that with organophosphate poisoning, so thus my title. We had a case where a 47-year-old male presented to the ER 50 minutes post-ingestion of a self-reported approximate 1 ounce of malathion. When he came to the ER, he was diaphoretic. He had some profound diarrhea already. He was oriented, but he was a little bit slow to answer questions, and his EKG was within normal limit, and that includes rate. There was no tachycardia, no bradycardia at that point in time. The staff in the emergency room became very, very concerned because the smell of the pesticide was very strong from the patient and the various fluids coming from the patient. And their ER staff began to complain of some headaches, some dizziness, and some nausea. So we got several calls, not only from the ER staff, but from the risk management people at the hospital. They were quite concerned for their staff members and wanted to know what some of the protection methods that they needed to do for their staff was. So that brings us to our first audience participation question here. You have your little clickers. So what is the appropriate protection for staff in this kind of a situation? What do the first responders and the nursing staff and the doctors, the people with direct patient care, what do they need to worry about? Would it be universal precautions are fine? Would they use an N95 respirator? Would they use goggles, surgical mask? Do we need to put the patient in a reverse airflow room, or are we going to do all of those things? So We are going to do all of those things. Very good, audience. So we're going to do pretty much all of these things. Now, I looked, and I really couldn't find a whole lot of data where there's actually guidelines for this, but we're basically going to do everything we can to make the staff taking care of the patients as comfortable as we can and to prevent them from any, regardless of whether it's just being a little uncomfortable or real actual toxic exposure to the organophosphate. We are going to make sure we dispose of the contaminated clothing and waste. One of our suggestions was also, as long as this was not a risk for the suicidal patient, you can even put some sort of a deodorizer, the oil of peppermint or oil of wintergreen in the room, as long as you keep it away from the patient so that they can't get to it, since this was obviously a patient at risk for self-harm. So we progress to 16 hours post-ingestion. At this point, our patient is in respiratory distress, and they are about to intubate. The diarrhea is worsening. The nurses have placed a rectal pouch on the patient. The patient also has a Foley catheter. At this point, they have only given 4 milligrams of atropine. They became concerned because after they gave the 4 milligrams of atropine, the patient became tachycardic. So the hospital team was reluctant to give more, despite our recommendations. So we also recommended that they give some pralidoxime, and that we give 30 mg per kg followed by 500 milligram per hour continuous infusion. And one of the questions that has come up in clinical practice is, how long is this stable? Because we don't really have a whole lot of experience using this. We don't get to use it a whole lot. So for pharmacists, you know, how can we make a 24-hour bag? How big a bag do we make? And so that has been data that in the past has been a problem getting. So how is it stable for continuous infusion? How long is it stable? And the options are 4 hours, 24 hours, 7 days, or 28 days. And so audiences picked 24 hours. We actually have stability data in the Annals of Emergency Medicine that shows that it is stable in various environmental conditions for up to 28 days. Now, you're probably going to change your bag for sterility reasons, obviously more often than that, but we do have stability data that shows that this is a really stable infusion, so it's not something that we're concerned about from a needing to change the bag more often than whatever your hospital requirements are. For the atropine, we recommended the 1 to 3 milligrams IV every 3 to 5 minutes as needed to control our pulmonary secretions, and then maintain that with an infusion of 10 to 20% of the loading dose. The stability on this is also at least 24 hours, so the nice thing about it is that we've got some stability information on those. 25 hours post-ingestion, we had both atropine and 2-PAM drips started. Labetalol was used to combat the patient's tachycardia. The secretions were improving on the drips. The NG secretions went down from 300 milliliters an hour prior to starting the drips in the morning to 20 mils per hour in the afternoon. Urine output went from 40 an hour, it also dropped. Stool output went from 50 an hour, and it also dropped. "30 hours post-ingestion, the patient self-extubated, and he self-extubated about 50 hours post-ingestion, but his ABGs were good, his lungs were clear, he's lethargic, he's able to answer questions, and his level of consciousness had dropped in the interim. He did not require a lot of sedation during his intubation. And he remained on the 2-PAM, 500 milligrams per hour, and atropine, 1 milligram per hour. Extubated on room air 42 hours post-ingestion, still on his drips, but they planned to stop 45 hours post-ingestion, which would have been about 24 hours of therapy. There were no longer a lot of secretions. There was no longer the odor that the staff had been complaining of. He was not sedated. He was alert and following commands, and he was also still on the atropine. So the questions that we have for our expert panel to consider is, how long do we need to maintain some of those contact precautions for our staff, for the medical staff, for the first responders essentially, and the staff that have direct patient care? And I'll take them one at a time so you can go ahead and. Don't jump all at once.
Yeah, I'll go ahead and there's a couple of considerations that you have to take into account for deciding how long to maintain the contact precautions. Secondary contamination is a real issue with the organophosphate pesticides. The organophosphate pesticides itself is actually usually a powder that is not miscible with water. So the formulations in which it's packaged and distributed are mixed with a solvent. And it's often the solvent that causes the odor that people detect. And so you have to consider the volatility of the substance and whether there's actually any contact with any residual pesticide. That's why, for one reason, it's much more of a concern for exposure to a liquid form, because that's more likely to have residual organophosphate in it. So your bodily secretions, such as the emesis or the diarrhea, are likely to have the organophosphate in them. But you have such a massive amount of diarrhea and emesis that you can rapidly deplete your body of any large cache. So if there's generally no detectable odor, I don't think you need to have the precautions. The negative airflow is to remove the volatilized VOCs associated with the carrier of the pesticide. And so obviously, again, if you're not smelling it, there's not going to be a significant amount of it in the room. So I would think you could discontinue those when you're no longer able to detect it. Now, obviously, it's got to be when somebody first walks into the room, because you can have issues of olfactory fatigue for some of these things.
Anyone else?
Well, I think, at least initially, that's normally when you worry about the protection. And then part of that is because when they first come in, do they have vomit all over themselves? Did they spill the product? Because this was an ingestion. Obviously, if it was on the skin or that kind of thing, it'd be a little bit more obvious. But the best thing to do is to try and remove it as much as possible. So, I mean, did they remove his clothing?
Yes.
You know, because that's the biggest thing right there.
They removed clothing, they showered him, they did all of the decontamination initially when he came into the ER, and they actually, I think, closed off part of the ER for a while.
Because a lot of times that's where the noxious smell is coming from, is when they first come in and rescue brought them in and none of that had been